The boy is turning blue, not metaphorically, not gradually. His lips are the color of a winter sky, and the oxygen monitor screams a number I've only seen in textbooks. 72%, then 68, then 64. Dr. Reyes! The nurse's voice cuts through my paralysis. If you don't do it, no one will. My hands are shaking so badly I can barely hold the laryngoscope. I'm 6 months into my residency at Hospital St. Halsted, and I've never intubated a real patient before. Only the mannequin in the simulation lab, with its rubber throat and forgiving anatomy that doesn't bleed or swell or die if you make a mistake. But the attending physician is stuck in another emergency across town. The anesthesiologist is in the OR with a trauma that can't wait. And this 13-year-old boy who came in 30 minutes ago for what his mother thought was a bad cold is suffocating in front of me. The tube feels impossibly heavy in my hand. The blade of the laryngoscope catches the overhead light, throwing reflections across the walls of the pediatric ER bay. His mother is screaming somewhere behind me. Security is trying to move her out, but her voice breaks through everything. Save him, please, somebody save him. I position myself at the head of the bed. The nurse, Lisa, I think her name is, places her hand on my shoulder. Not pushing, just steadying. You can do this, she says quietly. I've seen you practice. You know what to do. But what happened in the next 4 minutes would change everything I thought I knew about medicine, about my own capabilities, and about the razor-thin line between life and death that we walk every single day. My name is Dr. Noah Reyes, and most days I still feel like I'm playing dress-up in someone else's white coat. I'm 27 years old, first-year internal medicine resident at St. Halsted Hospital in a mid-sized American city where autumn leaves are just starting to turn, and Friday night football still draws bigger crowds than the movie theater. The hospital is a 100-year-old institution with modern wings grafted onto its original brick structure. A metaphor, I sometimes think, for how medicine itself works. Ancient knowledge updated with new technology, but still fundamentally about one human trying to help another survive. I grew up in Houston, Texas, the son of immigrants who sacrificed everything so I could have opportunities they never did. My mother cleaned houses until her knees gave out. My father drove delivery trucks, his hands permanently scarred from years of loading and unloading. When I got my acceptance letter to medical school, my mother lit a candle at church and my father cried for the first time I could remember. So every patient I see carries that weight. Every decision I make echoes with their voices, their sacrifices, their unspoken expectations that I'll be worthy of what they gave up. The thing about residency is that nobody tells you how much of it is just survival. You work 80 hours a week, sometimes more. You make decisions when you're so tired that simple arithmetic becomes difficult. You smile at patients and pretend you're confident when inside you're screaming that you don't know what you're doing, that you're terrified of making a mistake that could cost someone their life. My co-residents and I have a dark joke. Medical school teaches you what you need to know. Residency teaches you what you need to survive. The difference is vast and humbling. The morning started normally enough. I'd arrived at the hospital at 5:45 a.m., 15 minutes before my shift officially began, because showing up early was a habit my father had drilled into me. If you're on time, you're late, he used to say. I'd grabbed terrible coffee from the residence lounge, burnt and bitter, but caffeinated, and met my attending physician, Dr. Marcus Webb, for morning rounds. Dr. Webb was a 52-year-old internist with silver hair, wire-rimmed glasses, and a teaching style that oscillated between Socratic questioning and blunt assessment. He had a reputation for being tough but fair, the kind of attending who would let you make mistakes but never let those mistakes harm patients. "Good morning, Noah," he'd said, barely looking up from the patient list on his tablet. "Ready for another day of learning how little you actually know?" "Always, Dr. Webb." He'd smiled slightly at that. "Good answer. Humility is the beginning of wisdom. Let's round." We'd seen our admitted patients first. Mrs. Rodriguez recovering from a COPD exacerbation, her oxygen needs finally decreasing after 3 days of steroids and antibiotics. Mr. Franklin with newly diagnosed diabetes learning to manage his insulin, frustrated by the finger sticks and dietary restrictions, but gradually accepting his new reality. Young Sarah Kim, whose lupus flare was finally responding to treatment after we'd adjusted her immunosuppressants. Each bedside encounter was a lesson in clinical reasoning, in communication, in the art of balancing hope with honesty. Dr. Webb had this way of asking patients questions that revealed not just their symptoms, but their lives, their fears, their understanding of what was happening to them. "Mrs. Rodriguez," he'd said gently, "tell me what concerns you most about going home. And she'd confessed her fear, that she lived alone, that she'd stopped breathing once before and nobody had been there to help, that she was terrified it would happen again. That conversation had changed our discharge plan entirely. We'd arranged home oxygen, set up visiting nurse services, connected her with a social worker who could help coordinate her care. Medical treatment wasn't just about fixing the disease. It was about addressing the whole person, the whole life. Around 9 a.m., we'd rotated down to the emergency department to help with consults. The ED at St. Halstead was a 12-bed unit that served the city and surrounding rural areas, staffed by emergency medicine physicians who were skilled but often overwhelmed during busy periods. That's where we met Dr. Jennifer Cow, the attending emergency physician on duty. She was 38, sharp-eyed and efficient, with the kind of calm demeanor that came from having seen everything at least twice. "Marcus," she'd said when she saw Dr. Webb. "Got a couple for you. Elderly woman with altered mental status, possible sepsis, and a young man with new-onset atrial fibrillation. Take your pick." Dr. Webb had turned to me. "Which one do you want, Noah?" It was a test, of course. Everything was a test. "The altered mental status, more diagnostic complexity. Good choice. I'll supervise the AFib workup. Meet me back here in an hour." So I'd taken Mrs. Chen's case, 76 years old, brought in by her daughter, confused and febrile, and spent the next hour systematically working through the differential diagnosis. Urinary tract infection, pneumonia, medication side effect, stroke, encephalitis, metabolic derangement. Each possibility required specific tests, specific questions, specific examination findings. I'd ordered labs, complete blood count to check for infection, comprehensive metabolic panel to check electrolytes and kidney function, urinalysis to look for UTI, blood cultures in case of sepsis. I'd ordered a chest x-ray to rule out pneumonia. I'd performed a thorough neurological exam, checking her strength, sensation, coordination, cranial nerves, mental status. I'd taken a careful history from her daughter about medication changes. Had anything been added or adjusted recently? Any new over-the-counter medications? Any herbal supplements? About recent illnesses. Had she been sick? Exposed to anyone who was sick? About behavioral changes at home. Had the confusion come on suddenly or gradually? Had there been any falls, any head trauma? The daughter had been exhausted, worried, feeling guilty that she hadn't noticed her mother's decline sooner. "She seemed fine 2 days ago," she'd said. "A little tired, maybe. But then yesterday she started saying confused things, and this morning she didn't know who I was." By the time I'd presented my findings to Dr. Webb, likely UTI with associated delirium, start antibiotics and IV fluids, admit for monitoring, it was almost 11 a.m., and I was feeling pretty good about my clinical reasoning. That confidence lasted exactly 7 more minutes. The overhead page shattered the routine hum of the emergency department. Pediatric respiratory distress, ETA 3 minutes. All available personnel to pediatric bay. I saw Dr. Cow's expression shift instantly from calm to alert. She moved toward the pediatric section of the ED, and Dr. Webb gestured for me to follow. "Watch and learn," he said. "Pediatric emergencies are different. Kids compensate until they can't, and then they crash fast. Their physiology doesn't give you the warning signs adults do." We positioned ourselves in Pediatric Bay 3, where the nurses were already setting up. Oxygen ready, monitors prepared, crash cart positioned nearby. Lisa Chen, one of the senior pediatric nurses, was directing the preparation with practiced efficiency. She'd been a nurse for 15 years, had seen thousands of sick children, and had an almost supernatural ability to predict which cases would go sideways. The ambulance arrived with sirens wailing. The paramedics wheeled in a stretcher, and my first look at the patient made my stomach clench. He was a boy, maybe 13 years old, sitting upright because lying down made breathing impossible. His name, I'd learn, was Marcus Thompson, same first name as my attending, which somehow made everything feel more personal. He was thin, with dark skin now taking on a grayish tone, and his breathing was labored in a way that was immediately, viscerally wrong. Each breath looked like work. His nostrils flared with each inhalation, trying to pull in more air. The muscles in his neck strained, accessory muscles that shouldn't be needed for normal breathing, but were now essential. His chest sucked inward with each inhalation, what we call retractions, a sign that he was using every available muscle to pull air into his lungs. Between breaths, he couldn't speak more than 2 or 3 words before having to gasp again. His mother, Angela Thompson, climbed out of the ambulance behind the stretcher. She was in her late 30s, wearing scrubs from the nursing home where she worked, her face carved with terror. Her hands were shaking as she followed her son into the bay. "He woke up this morning with a cough," she was saying, talking fast, desperate to give us information that might help. "Just a cough, nothing serious. I thought maybe he was getting a cold, but it got worse throughout the day. By lunchtime, he was wheezing. I gave him his rescue inhaler, 2 puffs like always. By afternoon, he couldn't finish sentences without gasping. I gave him the inhaler again and again, but it wasn't working. It always works." "Why wasn't it working? Does he have asthma?" Dr. Cow asked, already listening to his lungs with her stethoscope. "Yes, since he was 6. Usually well controlled. He hasn't had a bad attack in 2 years. We keep up with his controller medication. He sees his pulmonologist regularly." This came out of nowhere. I watched Dr. Cow's face as she moved the stethoscope across Marcus's chest, front, back, sides. Her expression darkened with each position.
"Decreased air movement bilaterally," she said quietly to Dr. Webb. "Barely any wheezing. This isn't typical asthma." Dr. Webb stepped closer, his own stethoscope already in his ears. He listened, moved the diaphragm to different positions, listened again. When he looked up, his eyes met mine, and I saw something I'd never seen in them before. Concern bordering on alarm. "Noah, listen to his lungs," he said, his voice calm but urgent.
I stepped forward, suddenly aware of how young I must look to Marcus's mother, how uncertain I felt. I placed my stethoscope on Marcus's back and asked him to take a deep breath. What I heard made no sense. In a normal lung, you hear clear, flowing air sounds, like wind through trees, smooth and continuous. In asthma, you hear wheezing, high-pitched musical sounds as air squeezes through narrowed airways. In pneumonia, you might hear crackles, small popping sounds as fluid-filled airways open and close with each breath. But Marcus's lungs were almost silent, just faint, distant sounds, as if I were listening to someone breathing in another room, through walls and doors. The silence was more terrifying than any abnormal sound would have been, because it meant almost no air was moving. "Silent chest," Dr. Webb said grimly. "He's not moving enough air to even generate wheezing. This is life-threatening. Get a blood gas now. Start him on 100% oxygen via non-rebreather mask. Nebulized albuterol continuously, not just intermittent treatments. IV access, 2 large-bore lines. Push-dose IV steroids. Methylprednisolone 125 milligrams. IV magnesium sulfate. And call anesthesia stat. We need to prepare for intubation." The words, "prepare for intubation," sent ice through my veins. Intubation meant placing a breathing tube down someone's throat and into their trachea, taking over the work of breathing with a mechanical ventilator. It was a procedure I'd practiced in simulation, but never performed on a living patient. The mannequins in the sim lab didn't have swelling airways or hypoxic brains or terrified mothers watching. Lisa moved immediately, her hands quick and sure. She started an IV in Marcus's left arm, threading the catheter into the vein smoothly despite his thrashing movements as he struggled to breathe. Another nurse started a second IV in his right arm. They hung bags of normal saline, drawing up medications, administering the steroids and magnesium, while a respiratory therapist appeared with the nebulizer, setting up continuous albuterol, a bronchodilator that should open his airways if this was indeed asthma. But over the next 10 minutes, despite everything we were doing, Marcus got worse. His oxygen saturation, which had been 91% when he arrived, dropped to 87, then 84, then 81. His breathing became more desperate, more exhausted. Sweat poured down his face, soaking his shirt. His lips, which had been pink when he arrived, were starting to turn dusky, then blue. His eyes had a glazed quality that spoke of hypoxia, not enough oxygen reaching his brain. The monitor alarms kept escalating, beeping with increasing urgency as his numbers declined. Dr. Cow picked up the phone to call anesthesia, but after 3 rings it went to voicemail. She slammed it down and tried again. Same result. She called the operator. "This is Dr. Cow in the ED. I need anesthesia to Pediatric Bay 3 immediately for emergency intubation." The operator's voice came back, professional but bearing bad news. "Dr. Cow, anesthesia is currently in OR2 with a level 1 trauma, multiple GSWs, patient actively hemorrhaging. They can't leave. How long until they're available? Unknown. Could be 30 minutes. Could be 3 hours." Dr. Cow's jaw tightened. "Find me someone who can intubate. Anyone. Doctor." Webb tried calling the other attending internist in the hospital, hoping for backup, but he was managing a code blue on the medical floor, another patient whose heart had stopped, requiring full resuscitation efforts and the complete attention of the available senior physicians. We were alone, a pediatric patient in extremis, and the only physicians available were an emergency attending, an internal medicine attending, and me, a first-year resident who'd never intubated anyone outside of simulation. Marcus's oxygen saturation hit 79%. His lips were navy blue. His breathing was slowing, not because he was getting better, but because he was getting too tired to keep fighting. "We can't wait," Dr. Cow said, her voice tight. "He's going to arrest. Marcus, honey, we're going to give you some medicine to help you sleep, okay? And then we're going to help you breathe with a tube. You won't feel anything, I promise." Marcus could barely nod. He was beyond speaking, beyond protesting, his entire existence reduced to the desperate struggle for air. Angela Thompson grabbed Dr. Cow's arm. "What are you doing? What's happening to my son?" Dr. Cow turned to face her, and I saw the weight of what she was about to say. "Mrs. Thompson, your son's lungs aren't working well enough on their own. The airways are so swollen and constricted that almost no air is getting through. We need to put a breathing tube in his windpipe and use a machine to breathe for him until the medication can work to open his airways. It's a temporary measure, but it's absolutely necessary. Without it, his heart will stop. Will he be okay?" The question every parent asks, the one we can never truly answer. The question hung in the air, unanswerable, unbearable. "We're doing everything we can," Dr. Cow said, which wasn't an answer but was the only honest thing she could offer. She turned to Dr. Webb. "Marcus, you comfortable intubating?" Dr. Webb hesitated. Just a fraction of a second, but I saw it, and so did Dr. Cow. "I haven't intubated anyone in 15 years. I'm an internist, not an emergency physician or anesthesiologist. My skills are rusty, and pediatric airways are different from adults. Smaller, more anterior, less room for error. But you can do it if there's absolutely no other option." "If there's no other option, I'll do my best, but I can't guarantee success, especially given how edematous his airway probably is from the inflammation." Marcus's oxygen saturation dropped to 72%. The alarm became a constant shrill scream. His eyes were rolling back. His breathing was slowing to occasional gasps. "He's going to arrest," Lisa said urgently, her voice cutting through the chaos. "His heart can't take much more hypoxia. We're out of time." Dr. Cow made a decision, her face set. "I'll intubate him. I've done hundreds. Get me the intubation tray, pediatric size, and draw up etomidate and rocuronium." But as she reached for the equipment, her pager went off with a harsh beep. She glanced at it, and her face went ashen. "Trauma alert. Multi-vehicle accident on Highway 40. Multiple critical casualties. ETA 2 minutes." She looked at Dr. Webb, anguished, torn between two impossible situations. "I have to be there. I'm the only ED attending on duty, and if it's multiple criticals, they'll need me to triage and direct care. Marcus, you have to intubate this kid. Or," she looked at me, really looked at me for the first time, as if assessing something beyond my medical knowledge, beyond my credentials, trying to see if there was something inside me that could rise to this moment. "Or you train him through it. There's no other option." She was already moving toward the trauma bay, calling orders to her nurses, preparing for whatever horror was about to come through those doors. The wail of approaching sirens confirmed the incoming disaster. "Doctor." Webb stood frozen for a moment, and I could see the calculations running behind his eyes. The terrible mathematics of emergency medicine, where sometimes there are no good options, only less bad ones, where sometimes you have to choose between risking failure and guaranteeing death. Then he turned to me, and in his eyes I saw something I'd never seen before. Not just trust, but necessity. "Noah, have you practiced intubation?" My mouth was dry. "In the sim lab, maybe 20 times on the mannequin, but never on a real patient. Never on a child. Then today you learn. Because if we wait for help that might not come in time, this boy dies. Come here." The intubation tray lay open on the bedside table like a surgical altar, each instrument precisely arranged, waiting. Laryngoscope, the L-shaped instrument with a blade and light used to visualize the vocal cords. Endotracheal tube, a flexible plastic tube that would go down Marcus's throat into his trachea. Stylet, a metal wire inserted inside the tube to help guide it and maintain its shape. Syringe to inflate the cuff that would seal the tube in place. Tape to secure it once positioned. Simple tools, impossibly complex task. Dr. Webb positioned himself at the head of the bed, with me on one side and Lisa on the other. Marcus was barely conscious now, his eyes half closed, his breathing shallow and rapid, each breath a desperate gasp that accomplished almost nothing. "First, we pre-oxygenate," Dr. Webb said, his teaching voice steady despite the urgency, despite the crisis unfolding. "The goal is to fill his lungs with as much oxygen as possible before we give medications that will stop his breathing entirely. Lisa, bag him with 100% oxygen." Lisa placed a bag valve mask over Marcus's face, creating a seal with one hand while squeezing the bag with the other, forcing oxygen into his lungs manually. With each squeeze, Marcus's chest rose slightly. The oxygen saturation climbed marginally, from 72 to 76 to 79 to 82. Every percent was precious, buying us seconds. Good, that buys us time. Maybe 90 seconds, maybe 2 minutes before his saturation crashes again once we give the paralytic. Now, Noah, we need to give medications before intubation. Do you remember the rapid sequence intubation protocol? My mind raced through the training I'd received. Lectures that felt like years ago even though they'd been mere months. Sedative and paralytic. We need to sedate him so he's not aware, and paralyze him so his muscles relax and we can visualize the cords more easily. Correct. We're using etomidate for sedation. It's hemodynamically stable, won't drop his blood pressure. And rocuronium for paralysis. Lisa, draw up etomidate 0.3 milligrams per kilogram and rocuronium 1.2 milligrams per kilogram. He weighs, Dr. Webb glanced at the chart, 48 kilograms. Do the math, Noah. Even in crisis, he was teaching. Etomidate 14.4 milligrams. Rocuronium 57.6 milligrams. Round to etomidate 15, rocuronium 60. Close enough for clinical purposes. While Lisa prepared the medications, Dr. Webb walked me through the procedure step by step, his voice calm, methodical, a lifeline in the chaos. Positioning is everything. The goal is to align 3 anatomical axes, the oral axis, the pharyngeal axis, and the laryngeal axis, into a straight line so you can see from the mouth directly down to the vocal cords. We do this by tilting the head back slightly and lifting the jaw forward, the sniffing position like he's smelling flowers. In pediatric patients, you need less head extension than adults because their larynx is more anterior. He demonstrated the position with his hands, showing me the angle, making me understand not just what to do, but why. You'll use the laryngoscope to lift the tongue and epiglottis out of your line of sight. The blade goes into the vallecula, the small pocket between the base of the tongue and the epiglottis. You lift anteriorly, not posteriorly. You're not prying his mouth open like a bottle cap. You're lifting his jaw and tongue up and forward, creating space to see. Once you visualize the vocal cords, and they look like a pale white V shape, sometimes you'll see them moving if he's still making respiratory effort. You'll pass the endotracheal tube through them, into the trachea. You'll know you're in the right place because you'll see the tube pass between the cords. Once it's in, we inflate the cuff to seal it, remove the stylet, and confirm placement by listening for breath sounds over both lungs and checking end-tidal CO2. What if I can't see the cords? My voice was shaking. Dr. Webb looked me directly in the eyes. Then you reposition and try again. External laryngeal manipulation. Have Lisa press on his neck to bring the cords into view. But Noah, his voice dropped lower, more serious, making sure I understood the stakes. You have maybe 2 attempts, possibly 3 if we're lucky. After that, his oxygen saturation will be critically low despite our pre-oxygenation. His brain will be starved of oxygen. His heart will start to fail. We'll have to move to a surgical airway, and I haven't done a crick in 20 years. The weight of that statement was crushing. A surgical airway, cricothyroidotomy, meant cutting through the front of his neck to access the trachea directly. It was a last resort procedure, brutal and dangerous, especially in a child. Angela Thompson had been moved to the corner of the room by security, but she was still within earshot, still hearing every word. I could hear her crying softly, murmuring what might have been prayers, might have been pleas to a God who seemed very far away at that moment. Ready? Dr. Webb asked. I wasn't. I would never be ready. But Marcus's oxygen saturation was dropping again. 81, 79, 77, and there was no one else. No cavalry coming over the hill. No experienced anesthesiologist to take over. Just me, my training, and the desperate hope that it would be enough. Ready, I lied. Lisa positioned herself at Marcus's side, one hand holding the IV line, the other ready to provide assistance. You've got this, Dr. Reyes, she said quietly. I watched you practice in the sim lab last week. You were smooth, confident. This is the same, just with real stakes. But the skills are the same. Her confidence in me was almost more terrifying than the procedure itself. Push the meds, Dr. Webb ordered. Lisa injected the etomidate first, the sedative that would make Marcus unconscious within seconds. Then the rocuronium, the paralytic that would stop all his muscles from working, including the muscles that controlled breathing. Within 15 seconds, Marcus went completely limp. His jaw went slack, his eyes closed, and his breathing stopped entirely, completely, as if someone had flipped a switch. It was one of the most terrifying things I'd ever witnessed. A living child suddenly motionless, suddenly dependent entirely on Lisa's hands squeezing the bag to keep oxygen flowing into his lungs, keeping his brain alive, keeping his heart beating. The monitor showed his oxygen saturation starting to drift downward, 77, 75, 73. You have about 60 to 90 seconds before his saturation becomes critical, Dr. Webb said, his voice steady but urgent. Take the laryngoscope. Position yourself at the head of the bed. Remember your training. I moved into position, my legs shaking so badly I worried I might fall. I gripped the laryngoscope in my left hand, handle in my palm, blade extending outward, the light flickering on as I tested it. Open his mouth. Insert the blade along the right side of the tongue, then sweep it to the left to move the tongue out of your view. I placed my right hand on Marcus's forehead, stabilizing his head. With my left hand, I inserted the laryngoscope blade into his mouth. His lips were cold. The blade clicked against his teeth, and I worried momentarily about breaking them, then pushed the thought away. Broken teeth could be fixed. Death couldn't. I swept the blade to the left, pushing his tongue aside. But all I could see was a mass of pink tissue, glistening and wet, with no clear landmarks. No obvious pathway to the vocal cords. Just undifferentiated anatomy that looked nothing like the clean, simple diagrams in textbooks. I can't see anything, I said, panic creeping into my voice. You're not deep enough yet. Advance the blade further, into the vallecula, the space between the base of the tongue and the epiglottis. You'll feel a slight give when you reach it. Then lift forward, not back. You're lifting the jaw, not prying the mouth open like a lever. Lift anteriorly, toward the ceiling. I advanced the blade deeper, feeling it slide along tissue, warm and slippery. My hands were slick with sweat. The laryngoscope kept threatening to slip in my grip. I found what I thought might be the vallecula and positioned the blade. Now lift, firmly but controlled. I lifted, pulling forward and upward, trying to remember the angle from simulation. And suddenly, there, barely visible, partially obscured, I saw them. The vocal cords, two pale strips of tissue forming a V shape, the gateway to the trachea. They were partially hidden behind the epiglottis, which was swollen and inflamed, but they were there. I see them, I breathed, afraid to move, afraid to lose the view. Good, excellent, don't lose them. Keep your view steady. Now take the ET tube in your right hand and pass it through the cords. Watch it go through. Visualize the entire passage. Lisa handed me the endotracheal tube, a size 6.5 for a pediatric patient, with the stylet already inserted to maintain its curved shape. I guided it toward the opening with my right hand while maintaining my view with the laryngoscope in my left. But as I advanced the tube, my angle shifted slightly, my hand wavered, and my view disappeared. Just pink tissue again, the cords lost behind swelling and anatomy. I lost them, I said, my voice rising with panic. The monitor showed his oxygen saturation dropping. 68, 65, 62. Reposition? You're okay. You haven't failed yet. Find them again. Minor adjustment. I adjusted the laryngoscope, lifting more, angling slightly differently. The cords came back into view, but they looked different now, more anterior than before, harder to access. Lisa, external manipulation, Dr. Webb ordered. Press on his larynx, move it posteriorly. Lisa placed her fingers on Marcus's neck just above his thyroid cartilage and pressed backward. Like magic, the cords shifted into better view, more centered, more accessible. There, perfect. Now pass the tube, quickly, his saturation is critical. I looked at the monitor. 58%. Then 55, we were running out of time. Marcus's heart rate was climbing. 120, 130, 140, his cardiovascular system responding to severe hypoxia. I guided the tube forward again, this time keeping my view locked, refusing to let my hand waver, refusing to lose sight of the cords. I watched the tip of the tube approach the V-shaped opening, slip between the pale cords, and disappear into the darkness of the trachea below. "It's in," I said, my voice cracking. "How far?" "Check the depth marker." I glanced at the black markings on the tube where it met his teeth. 21 centimeters at the teeth. Good depth for his size. "Inflate the cuff. 10 milliliters. Lisa handed me the syringe attached to the pilot balloon. I injected 10 milliliters of air, inflating the small balloon near the end of the tube that would seal it in place in the trachea, preventing air from escaping around it. "Remove the laryngoscope and stylet. Attach the bag." I pulled out the blade and the metal stylet. Then Lisa immediately connected the bag valve device to the end of the tube and squeezed. Marcus's chest rose beautifully, symmetrically, for the first time since we'd paralyzed him. A good sign, but not confirmation. The tube could still be in his esophagus, in his stomach, inflating his belly instead of his lungs. We needed more evidence. "Listen for breath sounds," Dr. Webb ordered. I placed my stethoscope on the right side of Marcus's chest and listened as Lisa squeezed the bag. Clear breath sounds, air moving in and out. I moved to the left side. Clear breath sounds there too, equal and bilateral. "Breath sounds present bilaterally," I confirmed, my voice shaking with relief. "Check the CO2 detector." Lisa attached a small colorimetric device to the tube, a simple tool that changed color in the presence of carbon dioxide. It turned bright yellow immediately, confirming that the tube was in the trachea where exhaled air containing CO2 would pass through it, not in the esophagus where there would be no CO2. Yellow, good placement. "Secure the tube with tape. Someone call for a portable chest X-ray to confirm final position. And get him on the ventilator. Start with pressure control. Tidal volume 300, rate 20, PEEP 5, FiO2 100%. Lisa taped the tube securely in place across Marcus's cheeks and around his head, while another nurse wheeled the ventilator over and began connecting tubing. Within a minute, the mechanical ventilator was breathing for Marcus with rhythmic precision. In, out, each breath measured and controlled. The oxygen saturation began climbing almost immediately. 60, 68, 75, 82, 88, 94, 98. Marcus's color transformed before our eyes, from gray-blue to merely pale, from deathly to viable. His heart rate began to slow from its panicked 140 down toward normal ranges. His blood pressure, which had been climbing from stress, began to stabilize. I stepped back from the bed, my legs suddenly unable to hold me, and caught myself against the wall. My hands were shaking uncontrollably. Sweat poured down my face, my back, soaking through my scrubs. I'd done it. I'd intubated a real patient, a dying child. Dr. Webb placed both hands on my shoulders, steadying me, his eyes intense behind his glasses. "Well done, Noah. You just saved his life. That was textbook technique under extreme pressure." But I couldn't feel relief yet. Not entirely, because the intubation was just the beginning. Now we had to figure out why this had happened. Why a teenage boy with previously well-controlled asthma had suddenly crashed so catastrophically, and how to fix it before we could safely remove the tube and let him breathe on his own again. Angela Thompson approached slowly, hesitantly, as if afraid of what she might see. Her son lay motionless on the stretcher, a tube protruding from his mouth, taped across his face, connected to a machine that now breathed for him with mechanical precision. His chest rose and fell in perfect rhythm, but it wasn't him doing the breathing. It was the ventilator, taking over the most basic human function. "Is he okay?" she whispered, her voice barely audible. Dr. Webb's voice was gentle, carefully measured. "He's stable now, Mrs. Thompson. The tube is helping him breathe while we treat the underlying problem. Dr. Reyes intubated him successfully on the first attempt, which is excellent. It means minimal trauma to his airway. He's getting adequate oxygen now, and all his vital signs are improving." She looked at me, really looked at me, and I saw the question forming in her eyes before she spoke it. "How old are you? How many times have you done this? Was my son just practice for a resident who's still learning?" "You saved him?" she asked me directly, needing to hear it from my voice. "We all did," I said, deflecting automatically. "It was a team effort." "Everyone here? But you put the tube in?" There was no point in evading. "Yes, ma'am." She studied my face for a long moment, and I could see her working through complex emotions, gratitude warring with fear, relief mixing with anger that the situation had required her 13-year-old son to be intubated at all. Then she grabbed my hand suddenly, squeezing so hard it hurt, her grip desperate and fierce. "Thank you." Thank you for not being afraid to try. Thank you for saving my baby. But I had been afraid. I was still afraid. My hands were still shaking, my heart still racing, adrenaline still flooding my system. I was terrified, I admitted, because she deserved honesty. I've never done that before on a real patient. Never? Her eyes widened. Never. But Dr. Webb was right there guiding me through every step, and I've practiced dozens of times in simulation. I knew what to do, I just had to trust my training. She looked at Dr. Webb, then back at me. So my son was your first? Yes. I waited for anger, for accusation, for the entirely justified rage of a mother whose child had been used as training material in a life or death situation. But instead, tears filled her eyes and she pulled me into a fierce hug. Thank God you were brave enough to do it anyway, she whispered into my shoulder. Thank God you didn't let fear stop you. Because if you had, my son would be dead right now, and I would be planning a funeral instead of waiting for him to wake up. Over the next hour, we worked systematically to stabilize Marcus completely and investigate the cause of his crisis. The portable chest X-ray confirmed good tube placement, the tip positioned perfectly in the mid-trachea, about 2 centimeters above the carina where the trachea splits into the right and left bronchi. But the X-ray also revealed something else, a large infiltrate in the right lower lobe of his lung, pneumonia. Dr. Cow returned from the trauma bay after stabilizing the accident victims enough to hand them off to the surgical team. She examined Marcus, reviewed the labs that had been drawn, studied the chest X-ray with narrowed eyes. This makes sense now, she said, pointing to the cloudy area on the film. This isn't just asthma. He probably had a viral upper respiratory infection that progressed to bacterial pneumonia. The infection caused inflammation in his lungs, which triggered an asthma exacerbation. The combination, infected lung tissue plus severe bronchospasm, created a perfect storm. His airways were both constricted from asthma and filled with inflammatory exudate from pneumonia. She ordered blood cultures to identify the causative organism, started broad-spectrum IV antibiotics to cover the most likely bacteria, and adjusted his ventilator settings based on the severity of his lung disease. He'll need to stay intubated for at least 24 to 48 hours, she explained to Angela. We need to give the antibiotics time to work, give the steroids time to reduce the inflammation in his airways. Once his lungs improve enough, we'll do a trial of spontaneous breathing to see if he can manage on his own. But for now, the ventilator is doing the work his lungs can't do. We admitted Marcus to the pediatric ICU, where specialized nurses and physicians could monitor him continuously. As they prepared to transport him upstairs, as they transferred him from the ED bed to the ICU stretcher with all his lines and tubes carefully maintained, Angela walked beside him, her hand never leaving his arm. She paused at the doorway of the ED and turned back to our team, to Dr. Webb, to Dr. Cow, to Lisa, to me. Thank you, she said simply, all of you, for not giving up on him, for working together to save him when it seemed impossible. After they left, after the ED returned to its normal controlled chaos of minor injuries and chronic complaints, Dr. Webb pulled me aside into the physician workroom. Sit down, Noah. I sat, suddenly exhausted, the adrenaline wearing off and leaving me hollowed out. You did exceptional work today, he began. Truly exceptional. But I need to ask you something, and I need you to be completely honest with me. How do you feel right now? I thought about lying, about putting on the brave face residents are supposed to wear, about pretending the experience hadn't shaken me to my core. But Dr. Webb had earned honesty. Terrified, I admitted. Relieved that it worked. Grateful that you were there. But mostly just terrified of what would have happened if I'd failed. He nodded, as if this was exactly the answer he'd expected. Good. That's the right response. If you'd said you felt fine, if you'd acted like it was no big deal, I'd be worried about your judgment. Fear is information, Noah. It tells you when the stakes are high, when you need to be careful, when you should ask for help. But I didn't have a choice. Someone had to intubate him. True. But here's what I want you to understand. You succeeded not despite your fear, but because of it. Your fear made you careful. It made you follow the protocol precisely. It made you listen to my guidance instead of rushing in with false confidence. Fear, properly channeled, makes you a better physician. He leaned forward, his expression serious. I'm going to tell you something that might surprise you. I could have intubated Marcus myself. My skills aren't as sharp as they were 20 years ago, but I've done it before. I could have done it again. I stared at him. Then why didn't you? Because you needed to learn, and Marcus needed someone who would approach the procedure with appropriate respect for its difficulty. If I'd taken over, you'd have learned nothing except that you weren't trusted. But by coaching you through it, you learned that you're capable of far more than you think. You discovered that with good guidance and proper technique, you can handle emergencies that terrify you. What if I'd failed? What if I couldn't get the tube in? Then I would have taken over immediately. I was ready to step in at any second, but I believed you could do it, Noah. And I needed you to discover that you believed it too. Confidence isn't the absence of fear. It's the ability to act effectively despite fear. And today you proved you have that ability. His words settled something that had been churning inside me since the moment I'd grabbed that laryngoscope. There's something else, Dr. Webb continued. Something I want you to remember for the rest of your career. Medicine is a team effort. Lisa steadied you with her words and her presence. I guided you with my experience. Dr. Cow trusted us to handle the situation when she had to respond to another emergency. Angela trusted us with her son's life. None of us succeeded alone. We succeeded together. That's what makes medicine beautiful and terrifying in equal measure. We're all dependent on each other. Thank you, Dr. Webb, for trusting me, for teaching me, for not taking over when it would have been easier. Don't thank me. Thank that boy upstairs for surviving long enough for you to learn this lesson, and then make sure you honor his survival by becoming the kind of physician who never stops learning, never stops growing, never becomes so comfortable that you forget how terrifying this work actually is. He stood, preparing to return to rounds. One more thing, Noah. You're going to replay that intubation in your head 1,000 times over the next few days. You'll think of all the things that could have gone wrong, all the ways it could have been smoother. That's normal, but don't let the what-ifs consume you. You succeeded. Marcus is alive. That's what matters. Marcus stayed intubated for 36 hours. I visited him every shift during those hours, even when I wasn't officially assigned to the ICU. I'd stand outside his room and watch through the glass as the ventilator breathed for him, the rhythmic rise and fall of his chest, the numbers on the monitors slowly, steadily improving as the antibiotics fought the pneumonia and the steroids reduced the inflammation in his airways. The pediatric ICU was a strange place, simultaneously high-tech and heartbreaking. Machines beeped and hummed. Monitors displayed colorful graphs of vital signs. But beyond the technology were children, small bodies fighting battles they didn't understand, and parents maintaining vigil with exhausted determination. Angela practically lived in that ICU room. The nurses brought her blankets, coffee, cafeteria food she barely touched. She slept in the recliner beside Marcus's bed, waking every time his monitors alarmed, which was often in the first 24 hours as his oxygen levels fluctuated and his ventilator settings were adjusted. She talked to Marcus constantly, even though he was sedated and couldn't respond. She told him about school assignments he was missing, his English essay on To Kill a Mockingbird, his algebra homework that his friend Jamal had offered to explain when he got back. She told him about messages from his basketball team, about how his coach said his spot on the starting lineup would be waiting. She told him about the video game tournament they'd been planning, how she'd been practicing so she could actually give him competition this time instead of losing embarrassingly in the first round. The mundane details of a life interrupted, waiting to resume. On the second day, around midday, I found Dr. Webb outside Marcus's room during my lunch break. He was reviewing the morning labs on a tablet, his reading glasses perched on his nose. "His white count is down," he said without looking up, "from 18,000 to 12,000. The antibiotics are working. That's good news." It is. And his chest x-ray this morning showed improvement in the infiltrate. Still there, but smaller. The inflammation in his airways is responding to the steroids. He finally looked up at me. "How are you doing with all this?" "I'm okay. I keep thinking about those few seconds when I couldn't see the cords, when I thought I'd lost my view and wouldn't be able to get the tube in. That's the moment that separates successful procedures from failed ones. Not panicking when something goes wrong, but methodically troubleshooting and trying again. You did exactly what you should have done. You repositioned, got external manipulation, and succeeded. That's not luck, Noah. That's skill and composure. It felt like luck. Luck is what happens when preparation meets opportunity. You'd practiced in the sim lab, you knew the anatomy, you followed the protocol. When you encountered difficulty, you adapted. That's medicine." He paused. "Do you know why I've been hard on you during residency? Why I ask you difficult questions and make you justify your decisions? To teach me? Partly. But also to prepare you for moments like this. Moments when there's no time to look something up, when you can't consult a senior physician, when you have to trust your own judgment and skills. I push you because I want you to be ready when the critical moment comes. And yesterday you proved you were ready. Angela emerged from Marcus's room, her eyes red-rimmed from lack of sleep, but brightening slightly when she saw us. Dr. Webb, Dr. Reyes, the nurse said Marcus is doing better? He is, Dr. Webb confirmed. His infection is responding well to antibiotics, and his lung function is improving. If this trend continues, we'll try removing the breathing tube tomorrow and see if he can breathe on his own. And if he can't, then we keep him intubated a bit longer and try again in another day or two. But I'm optimistic. He's young and otherwise healthy. His body just needed support while it fought the infection. Angela turned to me. Dr. Reyes, can I talk to you for a minute? Privately? Dr. Webb excused himself tactfully, and I followed Angela to the small family consultation room at the end of the ICU hallway. It was a sterile space with soft lighting, comfortable chairs, and a box of tissues on the table, a room designed for difficult conversations. I need to tell you something, Angela said once the door closed. Something I haven't told anyone else, and I'm not sure why I'm telling you except that you saved my son, and I feel like you deserve to know the truth. I waited, uncertain where this was going. I'm a nurse, she began. I told you that in the ED. I've been a nurse for 18 years. I work in a nursing home taking care of elderly patients. And because I'm a nurse, because I know how medicine works, I recognized what was happening to Marcus in that ED bay. She paused, gathering herself. I saw how young you looked. I saw your hands shaking. I heard Dr. Webb telling you it was your first time, and I was terrified. I thought, this kid is going to practice on my baby, and my baby is going to die because they couldn't get someone more experienced. I wanted to scream, to demand they find someone else, to refuse to let you touch my son. Her honesty was brutal, but I respected it. But then I watched you, she continued. I saw you listening to Dr. Webb's instructions. I saw you taking your time, being methodical, not rushing even though Marcus was dying. I saw your fear, yes, but I also saw your focus, your determination, your refusal to give up even when you couldn't see the cords at first. Tears were streaming down her face now. And I realized something. I'd rather have a scared doctor who understands the stakes and proceeds carefully than an overconfident doctor who rushes in carelessly. Your fear made me trust you, Dr. Reyes, because I knew you understood that my son's life depended on every move you made. I knew you wouldn't be reckless or arrogant. I knew every decision would be deliberate. She grabbed my hands, holding them tightly. So, thank you. Not just for saving Marcus's life, but for caring enough to be scared. For having enough humility to listen to Dr. Webb's guidance, for being exactly the kind of doctor I'd want treating my son, someone who knows what they don't know and proceeds with appropriate caution. I didn't know what to say. Her words touched something deep, validating the fear I'd felt ashamed of. Can I tell you something? I said. A promise? Please. I promise that 10 years from now, when I'm the experienced attending and some terrified resident is looking to me for guidance, I'll remember what it felt like to be in their shoes. I'll remember standing at the head of that bed with shaking hands, wondering if I could do what needed to be done. And I'll teach them with patience and respect, the way Dr. Webb taught me. I'll help them discover their own capability, instead of taking over and making them feel inadequate. Angela smiled through her tears. That's all any of us can hope for, that our suffering teaches someone else how to be better, how to be kinder. Marcus's crisis becomes your lesson, and someday your lesson will help another scared young doctor save another child. She hugged me then, a fierce, grateful embrace that carried the weight of a mother's relief and a nurse's respect. Thank you, she whispered again. Thank you for being brave enough to try when it would have been easier to wait for someone else. On day 3, Marcus was extubated. I made sure to be there, rearranging my schedule, asking another resident to cover my afternoon clinic so I could witness this moment. Dr. Patel, the pediatric intensivist, conducted the procedure with practiced efficiency, but she let me assist. First, they did a spontaneous breathing trial, turning off the ventilator's support and letting Marcus breathe through the tube on his own for 30 minutes. His oxygen saturation stayed stable at 96%. His respiratory rate was comfortable at 18 breaths per minute. His mental status was appropriate. He was following commands, squeezing hands when asked, moving his fingers and toes. He's ready, Dr. Patel said. She deflated the cuff that sealed the tube in place, then carefully pulled it out in one smooth motion while asking Marcus to take a deep breath and cough. Marcus coughed, a harsh, throat-raw sound that made everyone wince, but he breathed, clear, strong breaths that moved air into his lungs without mechanical assistance. His oxygen saturation stayed at 97% on just 2 liters of supplemental oxygen through a nasal cannula. Welcome back, Marcus. Dr. Patel said with a warm smile. "You've been asleep for a couple of days while we helped your lungs heal. How does your throat feel?" Marcus's voice came out as a raspy whisper, raw from the tube. "Hurts. That's normal. It'll feel better in a day or two. Can you tell me where you are? Hospital?" He croaked. "That's right. Do you remember coming to the emergency room?" His brow furrowed with effort. "Couldn't breathe. That's right. You had pneumonia combined with a bad asthma attack. But you're better now. Your lungs are healing." Marcus's eyes found his mother, who'd moved to his bedside the moment the tube was out. "Mom? I'm here, baby. I'm right here. You're okay. You're going to be fine." "What happened?" Angela looked at the medical team, unsure how much to explain, how to describe those terrifying hours to a child who'd been unconscious for them. I stepped forward, into his line of sight. "Hey, Marcus, I'm Dr. Reyes. I was one of the doctors who helped you in the emergency room when you came in." Marcus studied me with the frank, unfiltered assessment children have, seeing past the white coat and credentials to the person beneath. "You helped me?" "I did. You were having trouble breathing, so we had to put a tube in to help your lungs while medicine fought the infection. But you're better now, and we took the tube out. You're breathing on your own again." Angela squeezed his hand. "Dr. Reyes saved your life, Marcus. When you couldn't breathe, when your lips were turning blue, he put the breathing tube in that kept you alive." Marcus's eyes widened slightly. "Was it scary?" The question caught me off guard with its directness, its innocence. Children don't ask if you succeeded. They ask if you were scared. "Yes," I answered honestly. "Very scary. It was my first time doing it on a real patient." "But you did it anyway?" "Yes, because you needed help, and I was the one there to help you." He processed this with the seriousness children bring to important matters. "That's brave. My mom says brave isn't not being scared. It's doing the thing even when you're scared. Your mom's a smart woman. Were your hands shaking?" "Yes. So much I could barely hold the equipment." "But you didn't give up?" "No, I didn't give up." Marcus smiled slightly, a small curve of his lips that transformed his pale, exhausted face. "Cool." That single word, delivered with childlike simplicity, meant more than any praise from attendings or gratitude from parents. Because Marcus understood something fundamental about courage and fear and the choice to act despite uncertainty. He closed his eyes then, exhausted from just those few minutes of consciousness, and drifted back to sleep. But his breathing remained strong and steady, his chest rising and falling without assistance, his oxygen saturation holding stable. He was going to be okay. Marcus was discharged from the hospital 6 days after his admission. His pneumonia had resolved completely. His asthma was under better control with adjusted medications. His pulmonologist had added a daily controller inhaler and given detailed instructions about when to escalate treatment if he felt symptoms worsening. He'd regained the weight he'd lost and was complaining about the hospital food, which the nurses assured Angela was an excellent sign of returning health and normal teenage attitude. On discharge day, I found time between my morning rounds to visit him one last time. He was dressed in his own clothes, jeans and a black t-shirt with a superhero logo, looking like a regular kid instead of a patient. His mother was packing his things, folding clothes, organizing medications. "Dr. Reyes," Marcus said when he saw me. "Mom said you'd probably be too busy to say goodbye. I made time. Had to see you off properly." I held out my hand for a handshake, but Marcus ignored it and hugged me instead. A quick, awkward teenage hug that nonetheless carried real gratitude. When he pulled back, he held out a piece of paper folded in half. "I made this for you. It's not very good. I'm not really artistic. But Mom said I should give you something to remember me by." I unfolded it carefully. It was a crayon drawing, clearly done with the limited supplies available in a pediatric ICU, showing a stick figure in a white coat standing next to a bed with another stick figure lying in it. Above the scene, written in careful block letters, "Dr. Reyes saved me. He was scared but brave." My throat tightened unexpectedly. "Marcus, this is incredible. Thank you. You can put it up in your office or wherever doctors put stuff. So when you have to do scary things, you remember that being scared is okay if you do it anyway." The wisdom from the mouths of 13-year-olds. I will. I promise I'll keep this and look at it whenever I need to remember why I became a doctor. Angela finished packing and zipped up the duffel bag. "Ready, Marcus?" "Yeah." He turned back to me. "Dr. Reyes, I decided something while I was here." "What's that?" "I want to be a doctor when I grow up. Specifically, I want to help kids who can't breathe, like you helped me. I want to be the person who isn't afraid to try when someone's dying." "You'll be a great doctor," I said, meaning it completely. You already understand the most important lesson, that fear is okay if it doesn't stop you from helping people. Angela walked me out of the room while Marcus made his final round, saying goodbye to the nurses who'd cared for him. I want you to know something, she said quietly. Something I realized while sitting in that ICU for 3 days watching machines breathe for my son. I waited. I blamed myself at first. I kept thinking, I'm a nurse. I should have recognized the pneumonia developing. I should have brought him in sooner. But then I realized, sometimes things happen fast. Sometimes healthy kids get sick suddenly, catastrophically, and it's nobody's fault. The guilt was eating me alive until I accepted that. She paused, choosing her words. You're going to have cases that haunt you, Dr. Reyes. Cases where you wonder if you could have done something differently, something better. But I want you to remember Marcus. Remember that sometimes everything goes right. Sometimes the scared young doctor makes the right call, follows the right protocol, and saves the kid. Sometimes the story has a happy ending. Thank you for that. No, thank you for everything. And I mean this, if Marcus does become a doctor someday, if he helps save someone else's child, it'll be partly because of you. Because you showed him what courage looks like. You'll have saved more than one life. The weeks after Marcus's discharge were strange in their normalcy. I returned to the routine of residency, morning rounds, afternoon clinics, evening admissions, overnight calls. I saw patients with diabetes and heart disease, with infections and chronic pain, with anxiety and depression. I wrote orders, reviewed labs, documented encounters in electronic medical records, but something had shifted inside me. Before Marcus, I'd approached each procedure with dread, seeing them as tests I might fail rather than skills I could develop. I'd hidden my uncertainty behind false confidence, afraid that admitting ignorance would expose me as an imposter. After Marcus, I understood that fear was information rather than weakness. It told me when stakes were high, when I needed to be especially careful, when I should ask for help. Instead of fighting the fear, I learned to work alongside it, to acknowledge it, respect it, and then proceed anyway with methodical care. I also changed how I approached learning. I started spending more time in the simulation lab, but with a different mindset. Instead of practicing until I got it right once, I practiced until I couldn't get it wrong. I worked on intubation until my hands developed muscle memory, until I could visualize the anatomy without thinking, until the movements felt natural. But I also started seeking out the stories behind the procedures, the human element that textbooks don't teach. I talked to experienced nurses about what they'd seen work and fail. I asked senior residents about their scariest moments, their biggest mistakes, their most valuable lesson. I read case reports not just for medical details, but for decision-making under pressure, for how people handled uncertainty and fear. Dr. Webb noticed the change during our rounds one morning, about 3 weeks after Marcus's discharge. You're asking better questions, he observed as we reviewed a patient's case. More precise, more thoughtful, and you're more willing to say, I don't know when you're uncertain. I figured out that pretending to know is more dangerous than admitting ignorance. That's wisdom. Some physicians never learn that lesson. They hide behind false confidence their entire careers, and patients suffer for it. He paused outside a patient's room. Do you know what the most important quality in a physician is, Noah? I thought about it. Knowledge? No. You can always look up knowledge. Try again. Technical skill? Important, but not the most important. Once more. I considered what I'd learned from Marcus, from Angela, from my own fear and its aftermath. Humility? Dr. Webb smiled. Exactly. Humility to recognize the limits of your knowledge. Humility to ask for help when needed. Humility to admit mistakes and learn from them. Humility to understand that being a physician is about serving patients, not feeding your own ego. He placed a hand on my shoulder. You're becoming a good doctor, Noah. Not because you successfully intubated a patient, though that was excellent work, but because you're learning to integrate fear, uncertainty, and humility into your practice. Those qualities will serve you far better than any amount of pure medical knowledge. Over the following months, I successfully intubated 11 more patients. An elderly woman with respiratory failure from advanced COPD. Dr. Webb supervised but didn't coach, just stood back and watched as I performed the procedure smoothly. A middle-aged man who'd overdosed on opioids and stopped breathing. I intubated him in the field with paramedics, my first pre-hospital procedure. A young woman with epiglottitis whose airway was swelling shut. A terrifying case where I had to place the tube through a tiny opening, but I succeeded on the first attempt. Each case taught me something new. Each one added layers to my understanding, not just of the technical procedure, but of the human experience surrounding it. The fear patients felt, the trust they placed in me, the responsibility I carried. But Marcus remained special, my first. The one who taught me that the most important lessons often come not from success, but from the terror of potential failure. 6 weeks after Marcus's hospitalization, I received an email from Angela Thompson. Subject line, "Update on Marcus. Doctor. Reyes, I wanted to let you know that Marcus is doing wonderfully. His follow-up appointments have all been excellent. His lung function is back to baseline. His asthma is well controlled with the new medication regimen. He's back to school, back to basketball, back to being a normal 13-year-old who thinks he's invincible. He talks about you often. He tells his friends the story of how a doctor who was scared but brave saved his life. He's already researching medical schools. Yes, at 13. He's very determined. He's decided he wants to be a pediatric pulmonologist, specifically working with children who have asthma and breathing problems. I don't know if you realize the full impact you had, not just on Marcus's life, though obviously that's enormous, but on how he sees the world now. He understands that courage isn't the absence of fear. He understands that asking for help is strength, not weakness. He understands that sometimes the scariest moments become the most important ones. He also understands that young doesn't mean incompetent, that inexperience doesn't mean inability. He's more willing to try new things now, less afraid of failure, because he watched you succeed at something you'd never done before. Thank you for teaching my son those lessons. And thank you for teaching me that sometimes the youngest doctors, the ones still scared, still learning, still uncertain, are exactly the ones you want in a crisis, because they care enough to get it right. Marcus wanted me to tell you that he still has the breathing tube you used. We asked if we could keep it when he was discharged, and the hospital let us. He says it's his good luck charm, proof that scary things can have good endings. With eternal gratitude, Angela Thompson. I read the email 3 times, then saved it in a folder I'd created called Why I'm Doing This. It lived alongside my parents' congratulations when I got into medical school, a thank you note from an elderly patient whose pneumonia I'd diagnosed early, and a photo from my white coat ceremony. On the hard days, and there would be many hard days ahead, I would open that folder and remember why I'd chosen this path. Remember that medicine, despite its terror and responsibility and weight, was ultimately about helping people survive their worst moments. I printed Marcus's drawing and framed it. It hung in my small studio apartment, where I saw it every morning when I woke up and every night before I slept. A stick figure doctor and a stick figure patient with the words, "He was scared but brave," written across the top in a child's careful handwriting. A reminder that fear and courage aren't opposites, they're partners in the work of healing. 1 year after Marcus's hospitalization, I was supervising a 3rd-year medical student in the emergency department when a case came in. Teenage girl with respiratory distress, possible asthma exacerbation. The student, a bright woman named Jennifer who reminded me of myself a year ago, examined the patient and presented the case to me. As she talked, I watched the patient's work of breathing increase, watched the oxygen saturation slowly drift downward despite high-flow oxygen. "I think she needs to be intubated," Jennifer said, her voice tight with nervousness. "But I've never done it before. Should I page the attending?" I looked at her fear, her uncertainty, her desperate desire to do right by this patient, and I saw myself standing at the head of Marcus's bed, holding a laryngoscope with shaking hands. "Have you practiced intubation in the simulation lab?" I asked. "Yes, maybe 15 times, but it's different with a real patient, right? I mean, the mannequin doesn't die if you mess up." "That's true, but the basic skills are the same, and today you're going to learn on a real patient. I'll talk you through it, step by step." The way my attending talked me through my first intubation, her eyes went wide with fear and something else, maybe hope, maybe excitement. "But what if I can't do it? Then I'll take over immediately. But I think you can. And more importantly, I think you need to discover that you can. So let's get started." I guided her through it the way Dr. Webb had guided me. Clear instructions, steady presence, confidence in her capability even when she doubted herself. She visualized the chords on her second attempt, passed the tube smoothly, and achieved good placement that we confirmed with breath sounds and CO2 detection. When she stepped back from the bed, her hands were shaking, but her eyes were bright with accomplishment and disbelief. "I did it," she whispered, as if saying it too loud might break the spell. "You did, and you're going to remember this patient for the rest of your career. Your first intubation, The one that taught you that you're capable of more than you thought. Were you scared your first time? I told her about Marcus. About the shaking hands and the terror and the weight of responsibility. About Lisa saying, if you don't do it, no one will, and how those words had changed everything. About losing my view of the cords and having to reposition. About the oxygen saturation dropping into the 50s. About Dr. Webb's calm voice guiding me through the panic. The fear doesn't go away, I said. You just learn to work alongside it. You learn that being scared means you understand the stakes, that you're taking the situation seriously. And you learn to trust your training even when you don't yet trust yourself. Jennifer nodded, absorbing the lesson the way I'd absorbed it from Dr. Webb a year ago. Thank you for letting me do it. I know it would have been safer and faster if you'd done it yourself. Maybe. But safety isn't just about the immediate technical outcome. It's also about building competence in the next generation of physicians. You're going to be a doctor who saves lives. Today was your first step toward becoming that person. Did your attending tell you something similar? Almost those exact words. And someday, when you're a senior resident or an attending, you'll pass the same lesson on to someone else. That's how medical education works. We teach by showing, by trusting, by giving scared students the chance to discover their own capability. That evening, I went home to my apartment and looked at Marcus's drawing on my wall. The crayon stick figures, the carefully printed words, the child's perspective on courage and fear. My phone buzzed with a text from my mother. Your father and I are so proud of you, mijo. We always knew you would help people. I thought about all the people who'd helped me reach this point. My parents, who sacrificed everything for opportunities I'd almost been too scared to seize. Dr. Webb, who taught me that guidance is a higher form of teaching than taking over. Lisa, who steadied my shaking hands and trusted me to do what needed to be done. Angela, who saw past my fear to the determination beneath it. And Marcus, who survived long enough for me to learn that I was capable of saving a life. We don't become doctors alone. We're shaped by patients who trust us, by teachers who invest in us, by colleagues who support us, by families who believe in us. Every successful procedure, every correct diagnosis, every life saved is a collaboration, a web of human connection and shared purpose that extends back through generations of physicians and forward through the students we teach. That's what I'd learned in the year since I grabbed that endotracheal tube with shaking hands and discovered I could do something I'd thought was impossible. Medicine isn't about being fearless. It's about being scared and doing it anyway. It's about recognizing that uncertainty is inherent to the work, that mistakes will happen despite our best efforts, that growth requires risk and vulnerability. It's about asking for help when you need it and offering help when someone else needs it. And fundamentally, it's about honoring the extraordinary trust that patients place in us, the profound faith that lets them say, I'm scared, I'm suffering, I need help, and then allow us to try, even when we're not entirely sure we can succeed. That's the covenant of medicine. That's the promise we make when we put on the white coat and pin on the badge that says, Doctor. I'd made that promise to Marcus Thompson in a pediatric ER bay with his oxygen saturation in the 60s and his mother's screams echoing in my ears. And in making that promise, in grabbing that laryngoscope despite my shaking hands, in following Dr. Webb's guidance despite my terror, in refusing to give up when I lost sight of the cords, I'd made a deeper promise to myself. A promise to keep learning, to keep growing, to keep facing my fears for the sake of the people who needed me to be brave enough to try. A year later, I was still honoring that promise. I would honor it for the rest of my career, for every patient who needed someone to grab the tube with shaking hands and say, I can do this, I will do this, because if I don't, no one will. That's what it means to be a doctor. That's what Marcus taught me. And that lesson, learned in terror, confirmed in triumph, refined through repetition, would guide me through every difficult moment that lay ahead, through the scared medical students I would teach, through the complicated cases I would manage, through the failures I would experience and the successes I would celebrate, through the entire arc of a career, built on the foundation of one scared resident who chose to act despite fear. Marcus's drawing would hang on my wall through residency, through fellowship, through my first attending position. It would move with me from apartment to house to office. The crayon would fade slightly, the paper would yellow with age, but the message would remain clear. He was scared, but brave. 4 words that captured the essence of what it means to practice medicine. 4 words that would remind me, on the hard days and the impossible days, and the days when I questioned whether I was good enough or strong enough or brave enough, that I was, because Marcus had survived, Because Jennifer had successfully intubated her first patient. Because the chain of teaching and learning and trusting and growing continued, one scared student at a time, each one discovering that they were capable of more than they'd ever imagined. That's the gift Dr. Webb gave me. That's the gift I would spend my career giving others. And that's why, despite the fear and the exhaustion and the weight of responsibility that never fully lifts, I wouldn't trade this profession for anything. Because sometimes when you grab the tube with shaking hands and refuse to give up, you save a life. And sometimes, that changes everything.